We asked our speakers to prepare some initial abstracts, and 4 broad themes emerged which structured our initial thinking. First, what is the knowledge that can inform the improvement of healthcare and its development? What's the role of biomedical knowledge and its relationship to improvement knowledge? Second, what are the ways that knowledge systems can contribute to taking action for, or limiting indeed, the improvement of healthcare? 3, how do we engage clinicians in improvement? How do we teach this? What kinds of career paths are possible? And fourth, what the knowledge that underpins evaluation of efforts to improve healthcare. So, what happened? There's no popcorn, but there was a short movie that we're going to share with you now to give you a kind of a visceral sense of what happened at the Colloquium. I'm sure it will be buffering through any second. This is the black box. Yes, we're going to peer into it in a second. I'll just go back one slide and forward and just hope the movie's going to kick in. Yeah.
This conversation, which has begun, is a conversation that goes easily and without significant challenge. Actually, it's a lot of challenge to have this conversation.
And some of the frustration comes from how do we embed social science findings within a clinical environment?
I think it's long overdue. It's quite urgent that we do radically critique some of the taken for granted theories of change that have been in the field, some of them for some time. The debate we got into in our group was around the collaborative model. You know, that's still extant, that's still being used, and it's still very, very difficult to tease out what is the underlying theory of change that drives that.
I think patient safety research and policy making has sought to create more knowledge, and I think what we are underestimating is the importance of creating safety through non-knowing, or the ability to be surprised, the ability to be attentive, and that comes from not assuming that you know the situation. And the other thing is that research and policy making has constantly anchored itself in objectivity, whereas I think the role of emotion is something that we have not really begun to engage with, as something that can productively contribute to what we're talking about here.
I think the world economy is going to be telling healthcare that there has to be a massive reduction in costs. So I hope part of what we're thinking about is to say, how are we going to bring along issues of quality when the cost impact that we're going to have in healthcare in my country, and perhaps some of the other ones represented here, may be on the order of 25%. How will we do that?
We moved on to a discussion of it was a little bit different, but kind of Kuhn structure of scientific revolution, which has these 3 stages, I learned. Pre-paradigm, to normal science, and then to revolutionary science. And we had a rather lively discussion about sort of where does QI fit in that, and where does improvement interventions fit in that, this continuum of scientific revolution.
What I hear, and this is really my first immersion in this discipline, is a concept that is very difficult to penetrate the traditional biomedical model, is the notion of a treatment as a social change. When you bring that into traditional biomedical discussions, they don't, at some level, they don't understand what you're talking about, because we think of the treatment as the imaging, as the drug, as the device, as the actual intervention. And everything around that is simply sort of window dressing, context. And so I think that's what interferes with the understanding of what a safety intervention is, because it doesn't have the same trappings as other biomedical interventions.
there's a sort of a feeling about, the pre-paradigmatic state as being a problem, and we should move as fast as possible to having a paradigm. And I feel very uncomfortable about that, and I would argue in praise of pluralism, which is what this conference is about, I think.
Sometimes I think about the patient safety movement and looking back and how it differs from quality and why things that were known about for 50 years have, suddenly become a big priority. And a big key transition seems to me that whether it's road safety or patient safety or whatever, is that there's a point at which things become unacceptable. And what was tolerated suddenly becomes no longer tolerated in a sort of wide social sense. And it seems to me that us as citizens, if you like, if I go back to David's point about the apps, we want the demand for better healthcare to be more widely spread, and in fact the current situation to be less tolerated, which we would want in this room. But I think if we only work through the professional organisations, we'll never get there.
I think there's a better need for a dialogue between the evidence-based medicine movement and the quality improvement movement. Because the evidence-based medicine movement, I realise, has been mostly focused on the new technologies coming in. Whether I should be doing them at all. Is this a worthwhile thing? Is it effective at all? What's the number needed to treat? Is this a great thing? And trying to get rid of things that are a waste of time as well, completely. Yeah. And it's just, but we only do a 50% job when they get in. Okay, so we accept the right things, that's the sort of evidence process, but we then don't try and improve those, whereas you guys, the quality improvement movement's been focused on the things that have gotten in the door, but you're now trying to make them work properly. And I think you have to recognise the dynamic system and pay attention to them both.
Reflecting back on my early days as an HIV doc in San Francisco, frankly, the patients were in our face. And it was often quite uncomfortable, but it made HIV care much better. It made it, even speaking as an academic, we were forced to organize our care in a way that took advantage of resources in the community and created or assisted in the creation of supports that weren't there.
Have you looked around and seen our colleagues? Not a Christine Keener among them.
No, have not seen that. No, it hasn't.
I'm afraid they're all down the road, lounging about at the International Colloquium of something even less useful.
There seems to me to be a question emerging about how we position the future development of improvement science, because we could position it as an evolution of where we are now, or we could position it as something radically different, a real revolution in the way that we're thinking. And there's some points that have come out, particularly in our group, I think, about the extent to which taking forward improvement science has to integrate the traditional disciplines of research and education and improvement activity. And the question is whether that integration produces something which is a compromise in each of those three disciplines, 3 areas of practice, or whether it's something that's very new and not a compromise.
We've got to change the unit of analysis, and I think you've inadvertently advised me about that. We've got to stop thinking hospital or structure or institution, start thinking system or community. The successful parts of the English health system are where people have lowered the boundary and started to span those boundaries, mobilise themselves socially to make things a little better. It's got a long way to go.
I wanted to echo Paul's thanks for both having this meeting and certainly for including me. I feel like many of the people out there who are not aware of the richness of this discipline and who we feel like we have to wake up. I was one of those. And going back to epistemology, I lived. You don't see the paradigm that you're in. It's like the water that the fish swim in or the air that you breathe. You can't see it. And I came to this meeting, and all of a sudden, I saw it. And before, I tended to think of QI, or whatever we're going to call it, as, sort of a lower level intellectual activity to which maybe the best scientists wasn't worth spending their time. And now I take on the admonition of a statistician who once pulled me aside and said, don't worry about the little things, work on the big things. I now think this is one of the big things to which not only do I think it's worthy of my attention, I think I'd be very honored to think that I even was able to contribute as a small part to its advancement. And it's so complex, it's far more complex, in fact, than many of the things that I've ever given my attentions to. So I want to thank you and everybody here for waking me up to that.
Every time I see that, I appreciate the work that Dale did in editing that. Let's just give him a hand. So what we did in the course of this session, or series of sessions, in both small groups and large groups, was to, as Dale suggested, people had prepared things beforehand, but it was an unusual meeting because we actually devoted more time to discussing what people had prepared than they had had to prepare. So we actually had this really intensive conversation, or series of conversations based on what people had prepared. And out of those conversations, and then we had those in small groups that were going on simultaneously, and then we came together in a large group. And we were busy keeping notes of all this stuff. And as we were doing that, making big boards of all that, and then Dale and Paul Bate and I spent some time trying to organize what were the emerging themes that were coming up. Because a lot of things were being sort of surfaced as worthy of further inquiry or further exploration. And that set of themes is what you see here. And these themes were the kinds of things that the group of people found as immediately relevant, something actually worth going after, and that they themselves were interested in. So it wasn't just sort of, it would be nice to know for somebody else, but this was something that was of interest enough to actually engage ourselves. And so on the basis of this listing of themes, small groups self-organized. We didn't set up the small groups this time. The people clustered themselves around the themes that they most wanted to develop further. And we spent some time then pushing into those and exploring them. And the ideas here that we've captured in this supplement are different than the traditional ways in which these supplements are put together. I mean, traditionally supplements are put together as collations of input documents that sort of reflect what people had prepared before they interacted around the material. This is more about outputs. So there are a few papers in here that sort of were reflective of, more largely reflective of the work people did before the colloquium. But the vast majority of the work in here was actually reflective of the work that occurred during the forum and after the forum. Because there was this great gift. Those of you who can try to do this are free to take on this challenge. But we actually were kind of proud that the Eyjafjallajökull, or whatever it is, the volcano from Iceland that came on Thursday night of this meeting. So everybody was getting ready to get their quick planes home, and suddenly there were no airplanes. And so we had this magical interlude after the conference was over where people had a chance to actually reflect on what they'd just been a part of. Well, you know, it's really hard to get that into the conference plan, but we were able to benefit from this, that then sort of set up the reflective thinking that's in the supplement. And in drawing from the words of the concluding chapter, and if I had to sort of suggest a path into this supplement, I might start at the last and then go back. But in the end, we recognize that healthcare, even at its most scientific and technical moments, is the provision of a social act. The provision of health care, to quote Frank Davidoff, is always, always a social act. And we recognized, as we were engaging in this, that our efforts were only a step on the journey. This is not the definitive thing in the epistemology of improvement. I mean, the world is wide open for the development of this thinking, in my view. And hopefully we've been able to do some labor in that field. But we're going to invite you into that conversation in just a few minutes. A couple more words from that concluding chapter in the supplement. Improvement will therefore, because it is always the provision of a social act, improvement will therefore lie in mastering the complex realities that drive and that inhibit human performance, professional behavior, and social change. And this slide violates all the canons of good slides. For example, the expression of individual and group self-interest, the ways that people assert power and control, the strength of group identity and communities of practice, the mysteries of context and its influence, the moral assumptions that underlie methods of evaluation, the importance of belief as well as understanding in knowledge, the strengths and limitations of groupthink, aka democracy, the enormous and mostly untapped power of cooperative, cross-disciplinary learning and action are all illustrative. And here's the nut. In short, we need to modulate our magical thinking about the value of tools and techniques by seriously entering into the alternate universe of Aristotelian phronesis, becoming capable of action with regard to the things that are good for humankind. So we came to this kind of a conclusion, and so it is that this supplement has been organized after we got the papers and with the benefit of some really marvelous work by the authors of these papers. We were then able to begin to cluster and group these papers into what seemed to us to be some aspects of these sort of underlying knowledge systems. One cluster, for example, had to do with the structure of improvement knowledge. How might we represent the structure? What's included? What's not included? How do we understand the nature of the relationship between evidence-based medicine and clinical quality improvement, for example? The second cluster had to do with evidence. How do we discover and define sources of evidence? The third cluster, the social determinants of action. The fourth cluster, the importance of cross-disciplinary work. The next cluster, the challenges of professional education. If in fact this is cross-disciplinary work, what kind of havoc does that raise with professional education that is usually done within a discipline or within a profession? And then the last cluster was rethinking the methods of inference. How do we actually draw out the lessons from these different ways of knowing and understanding? As we were bringing the week to a close, we began to ask ourselves, what next? What should happen next? How should we develop this interest, this work further? And one of the things that emerged in the very tail end of the conference and subsequent to the conference has been this interest by the Health Foundation to develop an improvement science fellowship for the UK and to be open to the possibilities of sibling improvement science fellowship relationships in other countries. And so this improvement science fellowship opened its application process, and this last week brought that to its first its first selection of the first 4 fellows, and these are fantastic people. I mean, there were 74 that were in this application process, and these 4 are stunning. I don't know whether Carl was here. Is Carl here? So, in the back. Raise your hand big so I can see it. Okay, there he is. Carl McRae is one of these 4. And my sense is that these 4 are really great exemplars of what we have in mind. They come from different fields, and that's purposeful on our part. And these improvement fellowships will offer these people the opportunity to develop their own ability to both lead and contribute to this emerging field of improvement science. In order to help make this a success, the Health Foundation identified an international advisory board which would be conceptualized as simply a group of folks who would encourage the development of a much broader community of practice or co-laboratory of individuals in the field. So this is not meant to be just the only group of people that have this interest, but rather a group that seeks inclusivity in its reach. And it's a treat for me to serve as the initial convening chair of that advisory board. And a third task of this program is to promote the field, is to continue to build this interest in the scholarly and scientific work that underpins the improvement of healthcare. So, as we were thinking about this presentation and our recitation of where we'd come, we thought it was really more important that we talk about the way in which this either makes sense to you or doesn't, because we actually are interested in trying to understand whether these themes actually resonate with you, and if so, in what ways. Is it helpful to think about the knowledge that underpins improvement as a form of science? How should clinicians, researchers, policymakers, and funders work together to develop improvement science? How might we know we're developing useful or good knowledge? So we were thinking, if you took the next maybe 5 minutes and worked just with a few people right around you, pick one of these questions. Have a conversation about that. And we'll be back into the game as a large group in 5 minutes. Go. He's fine. He's moved to Stanford. He's moving to Stanford from Johns Hopkins. He's leaving. But we had encouraged him to write even more. We got a review late back to his thing, and the reviewer was a good long-term friend who was initially hesitant to give the review, but when we said, no, actually you know him, so it's better to give him feedback. So Peter Margot was get that. And then Steve. I'd love to pick this up. I really would. I'm feeling a need to get back to the group here before So, what came up? What emerged in your conversation? Dale has the hand mic here. I think we'd be really interested to try to learn from what emerged in the conversations that you were having.
We did a whiteboard list of helpful and non-helpful for question 2.
Yeah.
Calling it a science.
Yeah.
We thought it'd be helpful in that it would give it a degree of validation, but that's balanced by the unhelpful bit of the need to justify it, and the antagonism that you immediately get from the established scientific method community, and that waste of time and energy justifying it. We had the attraction, but then the negative was that it excluded. And we had the benefits of attracting money and creating outputs, and the benefits of associating it with a discipline. And all of these had pros and cons. So when you said you didn't call it a science, you limited the outputs.
Yeah.
Did I get that? Single approach. Oh, and then finally, we really went to your opening slide, which was the realization that it was a combination of multiple disciplines.
Yeah.
And calling it a science sort of had the advantage of bringing them all together in one place and unifying that plurality.
Yeah.
But that could be seen as both a good and a bad thing.
Yeah, it's exactly right. I think it's a very helpful way to think about this. One of the interesting things that it evokes in me is the sort of the conversations over the years around whether quality improvement should be spelled with capital letters or not. You know, capital Q, capital I, or whether it's and are we going to get into that trap here where we're going to have a capital I, capital S improvement science as or should we think of this as a lowercase phenomenon that still does describe some coalescence of interest and contribution and so on. Thank you very much. Was there another one over here that Colin has a microphone? He can. Here's one. Okay, Dale. Yeah.
Thank you very much. Thank you. My name is Mir from Afghanistan. We briefly discussed with my colleague from Finland the last question: how might we know we are developing useful and good knowledge? I think we discussed that there are 2 very important things to have it. One, culture for improvement, and the second, a measurement system that tells you whether you are on the right track or not. But the third and very important thing that should be mentioned here, engaging both providers and receivers or customers in those changes that we are going to introduce. Then we will have some feedbacks from them whether the changes were really useful changes or they weren't.
Yeah, I think that's excellent. I think that's absolutely correct. I mean, my sense is that it will not be sufficient for us to sort of do this on simply a professional judgment of whether this is good and useful knowledge. We live in a social world, and it's a social change we're talking about, and that means being open to precisely the kind of standard that you suggest. Thank you. That's good. Here's one over here.
For me, I'm Jesper from Denmark. For me, it's not so abstractable about discussing whether it's a science or not. I'm much more interested in the action research part. You have to use your knowledge in specific contexts. And I really think that one of your points from 2003 is that the context is so important. So better use all your efforts, all your knowledge to help making improvements and evaluate whether it was an improvement. What I lack in this conference is very much how can we help each other testing if we are improving.
Yeah, I think that's right on point. As Frank Davidoff said earlier today in his session, learning and the experiential learning and the action learning that's involved in all of this is absolutely fundamental. And your point, how can we develop better evaluative methods that in fact will allow us to know what works where and under what circumstances and for whom and what the limits are of what we've introduced. And if we're holding a meeting like this in 10 more years and we haven't developed that, shame on us. I mean, my sense is that that really does need to be developed, and I think there's a cadre of people that are quite open to that and willing to work on that right now, and I'm excited about that. Dale?
Well, I also think it's about the spirit of collaboration. I mean, taking the example of evaluation, which has been a particular attention in the literature, I think oftentimes quality improvement folk and evaluation folk don't talk to each other and set themselves up in tension. I think the opportunity for evaluators, improvement people, funders, program designers to work together, I think will create much stronger programs and much stronger evaluations, working together in a process which says, what is your underlying theory of change? What are you trying to do here? What's the dosage of intervention that you're trying to do? At what scale? How many patients? How many clinicians? Given that dosage, where will you really see your effects? Which microsystems? At what tempo? What time? And having those conversations together means, I think, you can build evaluations that are closely aligned in their fit to the real life likely implementation of improvement interventions, and therefore I think get better results as a consequence. But my experience at the Health Foundation is that's hard to do, and it requires the real spirit of collaboration from the people wanting to enter into that kind of process and dialogue right at the outset.
Thank you. Colin?
Yeah, I'm Gary from Saskatchewan, Canada, and Health Quality Council. One of the things, looking at your question number 2 there, one of the things that we're doing in our jurisdiction to get clinicians, researchers, policymakers, and funders together is actually we've got a three-way partnership amongst the Quality Council, the government, and the university to fund an endowed chair for health improvement science research. And really that's to try to bring together an opportunity for interdisciplinary collaboration. So it will, by the structure of the university, it has to be located within a particular faculty, but it's really to try to work cross-disciplinarily to attract collaboration in an area that is, as was said in the video, is not looked on as an area of where there's a career path or where there's a lot of rigor, and trying to bring people together to look at it in a different way.
That's great. That's great. It's also good for our fellows to hear that there are jobs at the end of all this. There are some people in the audience here who actually attended this colloquium, and I think we should hear. There's Bo and there's David Stevens here. I think Frank Davidoff might be here, and there's Frank in the back. I wanted to give them a chance to say a few words. Is Ross Baker here? No, I guess not. And Duncan, I think, had another. And Charles Vincent had to leave. So I think, Frank, words?
Well, I think most of the useful words have probably already been spoken. Our little group did talk some about the third question there of collaborative or cross-disciplinary work, which emerged as a really important theme. And we talked a little bit about, well, what kind of work were we talking about? Was it really the work of thinking together or the work of actually developing and implementing programs together, which are related but clearly very different things? And the notion of somehow developing cross or multidisciplinary centers that actually had enduring support that helped to create real meaningful career paths and so on. In a cross-disciplinary career paths are almost an oxymoron. So it's a challenge, but might be one of the more fruitful areas to develop.
Yeah, and as we were thinking about this area after the conference, there's a growing movement in several places in the world where multidisciplinary teams are coming together for purposes of innovative both thinking and prototyping action. And our belief is that that's one of the possibilities that exists for this field as well. How about David or Bo? Okay. Hi. Yes.
Hi, Peter Luckman. This debate reminds me of when I was a sociology student 40 years ago, and we spent most of our time deciding whether sociology was a science or not, which indicated a kind of inferiority complex when compared to the real sciences that they were sought. And I'd hate for us to enter into that kind of debate that goes on for 30 years and we decide actually it doesn't really matter because it's a social movement.
I agree.
So the appeal is for your improvement scientists that they've got to use, the one thing from improvement methodology is they don't have time and they've got to learn from other places, and I'm pretty sure that Google and Apple don't spend their time thinking whether innovations are science or not. They continually improve their product, and they work out what the public want.
Good point.
Now, that's what we should be doing.
Yeah.
We should be continually improving our products and work out what the public wants, so that we don't spend our time just deciding whether we are science.
Yeah, yeah. I think you're absolutely right. And my sense is that the comment back here about action, learning, and what seems to me to be terribly important is to recognize that the folks that have this interest are deeply curious. I mean, they're not interested in defending a damn thing. I mean, they're deeply curious about how to make the experience of healthcare much better for patients and populations. And they themselves are driven by applying knowledge, but they are also curious people. And what is it that we might learn from resilience engineering? Or what might we learn from this group of patients? Or how and why? Well, why would we go ask these people about this? And what would they have to inform us? Because we're realizing that it's much more than just doctors and nurses. It's much more than just health professionals coming together that we actually have to work on if we view this as a social change process. And so for many of us, it's a discovery process. It's rather than some kind of a defensive mode. But I take your counsel. It's exactly to the point, it seems to me. David?
I think one of the comments, one of the observations that I would make about this colloquium and the subsequent activity around it is to compliment the leadership, Dale and Paul, in keeping alive the momentum that grew out of that meeting. We've all attended meetings other than the forum, by the way, which is also a meeting with continuity between sessions. But we live in an era where where we go and sit in a conference, whether it's under an ash cloud or not, where you sit there, talk to each other or talk at each other, and then go home, and then that's the end. We can't afford to have meetings like that ever again. And this is a wonderful model, Dale, and Paul, of taking. I mean, here is this. Supplement turned around in 1 year. That's an enormous length of time, and we've got to figure out how to do something like that in 1 month. And we can, because we have the tools to do it, but at least this is available on open access. And what's going on now are a bunch of the next or subsequent generation of ideas that have grown out of it. Yeah. One of which is, two of which Bol and I were just talking about. How do we know that knowledge is useful and good? Well, it used to be, it was peer-reviewed exhaustively, and then we cut down a tree and wrote on it and passed it around to all our friends, called a medical journal. Well, in fact, we have such technology available that why don't we do that iterative process right out of the blocks? When a new idea emerges and you're beginning to test it in an improvement context, put it out early. And let the peer review process take place online, and then it either happens or it doesn't. The second point is, tell that to your promotions committee.
Yeah.
But we have a little work to do.
Yeah, yeah. Well, I think we ought to bring this to a conclusion. Let me just sort of conclude by thanking you for coming and thanking all the people that made this really possible. This is available online, open source. Please use it, download it, and move it on. We're very interested in learning from you and with you. Thank you.
Thanks very much.